about bleeding during TURBT and after TURBT. So I think if we have listened to all the speakers previously and the way they have explained how to TURBT, probably we will face bleeding less. So coming to the bleeding part, in 1990, Dick explained that there is a risk of bleeding requiring transfusion around 13%, out of which 6% patients required transfusion on the day of surgery, whereas 7% required transfusion on a later date. In 1992, there was a paper which explained that bleeding was more associated with perforation. So patients who did not have perforation had a transfusion rate of 13%, and those who had perforation, the transfusion rate was around 24%. But recently, we have seen the rate of transfusion is less, and it's the bleeding complications is in the range of 1 to 4%. But of late, during last few years, we have been seeing gradual increase in bleeding complication, and probably it is because of more and more use of antiplatelets. So the risk factor related to the peri-operative bleeding, that is during surgery and after surgery, it can be divided into tumor related and host related and the technique related. So when it comes to tumor part, obviously where the tumor is large and multiple, and if they are at inaccessible sites, there is more risk of bleeding. And in the post-op period, if there is a bleeding, probably a missed upper tract tumor or a missed tumor in diverticulum can be a cause. Coming to the technique, as we heard now, usually there is less bleeding with bipolar than in monopolar, and in laser probably the bleeding is least. And over distended bladder, as it thins out the bladder, and obturator jerk, these two leads to a higher rate of perforation, and so the risk of bleeding is also more. And at times, obturator jerk results into a vascular injury. They are very uncommon, and one may need to open also. And most important is the surgeon's experience. Regarding patient factor, obese patient, as we know, it is very difficult to give a suprapubic pressure, as discussed earlier, long urethra and a large bladder, because it's difficult to reach the dome, and especially in a post-radiotherapy bladder and a recurrent tumor where the tumor is again at a previously operated site. These are difficult situations, and also when the patient is on antiplatelets or anticoagulants and they are having some bleeding or coagulation disorders, the risk will be more. So to decrease the risk of bleeding, we need to use continuous flow resectoscope, as the vision will be better. We need to avoid over distension and bladder and use lower current settings. Various method has already been discussed, especially with Jitin, and how to operate, and about how to operate in an anterior wall and a dome. And about this moving technique, in large tumors, we should follow moving technique where chances of bleeding will be less. So about the to decrease the jerk, it's a major obturator jerk is a major cause of perforation leading to bleeding. So there will be talk later to discuss how to decrease obturator jerk. Preferably a general anesthesia is required or a block, but it will be discussed later. Sorry. I'm not able to move the slide.
There is an arrow on the left lower side of the screen. You can click there.
No, sir, I'm not able to. Not able to slide down.
There is an arrow.
There is an arrow on the left lower half.
You can just use the up and down tabs.
Yeah, it's not working, sir. It's not working. Eight minute.
Yeah.
8 minutes, sir. I'll just go again. Yes.
Do the end show. Do the end show and go back.
Yeah. I'll make it, sir. Persistent. Yeah, I think. So now in a case of persistent intra-op hemorrhage, if we are not using a continuous flow resectoscope, we need to change to a continuous flow resectoscope, need to clear all the clots and do a systematic survey of a resected area to find out any active spurter to be controlled. And if there is just a diffuse venous ridge with or without small perforation and mild hematuria, we can just abandon the surgery and put a 22 French 3-way catheter and start bladder irrigation and observe. And anticoagulants can be given. And IV tranexamic acid can be given. And suppose if the bleeding continues, then what to do? Suppose the bleeding continues, then there are different ways. Not many cases has been done like that, and mostly there are case reports. So one method is using the fibrin glue, Avicel by Johnson and Johnson. They have a special catheter by which Avicel can be pushed over the bleeding area, and it has shown to control the bleeding. Similarly, there is a case report where they have used cyanoacrylate. What they have done is they have used 3 ml injections at 4 sites around the arterial spurter, injecting 5 millimeter deep, and which stopped the bleeding. They have used the normal resectoscope sheath with a needle, which is used to inject collagen, or we can use a Botox injecting needle also. The other thing which is commonly there in our OT is we can instill ferrochlorine 1%, and we can instill in bladder around 50 to 100 ml and keep it there for 5 minutes. Usually minor bleeding stop by this. Otherwise, if there's a persistent intra-op bleeding, as explained long back, it's a Helminstein technique. Actually, initially it was a bladder distension, but we can also use a specialized balloon where we can put a balloon over a catheter and distend the bladder. Initially, it was described for to cause tumor necrosis and used for 6 hours. But here we can distend the bladder with the balloon for a variable period of half an hour and so, and which will usually resolve the bleeding. If there is a vascular bleeding, usually it occurs as a torrential acute Peri-op bleeding and associated with obturator jerk. I have faced once when there was huge amount of bleeding. I had to open, and a vein which was attributed to internal iliac vein was perforated. Similar case report is there where during bipolar transurethral resection, external iliac injury was there, which had to be repaired by open surgery. So if still we are not able to control the bleeding, then we need to do a cystotomy and do underrunning of the vessels or do packing, though definitely it will increase the risk of local spread of tumor. Secondly, if there is an angioembolization facility in-house, that can be taken, we can take into account, or if that's not there, probably then in the last source we have to do an internal iliac artery ligation. Suppose now the surgery has been done and now the patient is still bleeding after 2 hours of surgery, and in the post-op, then what do we do? So then we have to do a reluxcystoscopy, remove all the clots, and then do all the hemostatic measures as we discussed earlier. So coming to the post-op hemorrhage, if in post-op hemorrhage the patient is having recurrent hematuria, then one thing is we need to do ultrasonography or CT urography if we feel we have missed some upper tract tumor or some diverticular tumors. Otherwise, we need to give oral and parenteral hemostatic agents, give supportive measures including blood transfusion and components as required, give and start antibiotics, and then we need to go for intravesical irrigation. 3 forms of irrigations has been described. One is formalin, other is alum and prostaglandin. Formalin 1 to 4% is usually used, though people have used till 10% also. We should rule out reflex, otherwise it will damage the ureters. Irrigation is usually done for 10 minutes with a pressure less than 15 centimeter of water, and the contact time is 15 minutes, and then it is washed by normal saline. Secondly, alum 1% can be used. 5 gram alum is dissolved in 5 liter of normal saline, and bladder is irrigated at a rate of 250 to 300 ml per hour. Prostaglandin, it's difficult to keep. The shelf life is you have to maintain a cold chain, but it can be used in 50 ml of 4 to 8 milligram per liter carboplast for 1 hour and can be repeated 4 times over 24 hours, or can be given as a irrigation of 100 ml per hour for 10 hours. Again, if the bleeding continues in post-op period, either we can go for hydrostatic pressure distension, Helminstein distension. It is done under epidural anesthesia where the bladder is over distended. Usually the pressure is 10 centimeter more than the diastolic pressure, and it's kept for 6 hours. So the patient need to be given epidural anesthesia. Instead of irrigation, we can use a Helmstein balloon distension as we discussed earlier. Otherwise, we need a hypofractionated radiotherapy. We can give 3 doses of 10 gray each, or otherwise the previous dose as 10 doses of 3 gray can be given. If we are still not able to control, we can take help of interventional radiology, where we can angioembolization of the vessels can be done. As we see here, this is a superior vesical artery territory and inferior vesical artery territory. So it was bleeding. After angioembolization, we see a dry area. There is no bleeding. So super selective embolization of bladder arteries are being done now routinely, and the side effects are also minimal. One other thing is not many studies are there. It's intra-arterial chemoperfusion with mitozentron, where mitozentron is used in a dose of 20 milligram per meter square surface area, and the dose is given in the desired area by arterial catheterization, and it's done over 1 to 2 hours. The results are good. The pain decreases more than angioembolization, but it takes little time to work. Coming to post where we are not able to control by these measures, then we have to go for a surgical measure. Surgical measure diversion is there, but only one study is there with around 9 patients where they have done some sort of ureterostomy, and which decreases bleeding, because the clot in the bladder acts as some pressure, and as the urine doesn't go into bladder, so there is less urokinase to dissolve the clot. Otherwise, the ultimate will be to do a radical cystectomy. There has been a study where 225 radical cystectomies were then, out of which 12 patients went and took this procedure because there was uncontrolled bleeding. So they underwent immediate radical cystectomy, and the results were good. So immediate surgical management seems feasible, safe, and efficacious. So the take-home message will be a meticulous and patient TURBT is key to avoid hemorrhage related procedure. Newer techniques like bipolar TURBT and laser make surgery more safe, and step ladder pattern should be followed to control hemorrhage. Thank you.
Thank you, Prem, for an exhaustive coverage of how to check bleeding. One quick question before Ganesh puts up his video. How do you make alum? How do you sterilize that solution? It's not available commercially.
No, yeah, it's not available commercially, and there is no clear-cut method to sterilize also. One way is they use some saline filters. What I could find in the literature was they use some saline filters. Otherwise, they just use the normal alum and dissolve it in saline.
Thank you, Prem.